In the name of Allah, today I am going to discuss another important topic of chronic pancreatitis. First of all, what is chronic pancreatitis? It is progressive, irreversible destruction of the pancreas caused by repeated attack of acute pancreatitis. Persistent pancreatic inflammation results in fibrosis, calcification, and permanent impairment of exocrine pancreatic function. Predisposing factors constitute chronic alcoholics, biliary tract disease, and hyperlipidemia. Pathophysiology of chronic pancreatitis. Repeated attack of pancreatitis cause increased pancreatic protein secretion with subsequent obstruction of the duct by protein-rich plaque and so produce chronic calcifying pancreatitis. Here are two pictures. In first picture, this is a normal picture of pancreas. If you put a probe in epigastric region in transverse section, we can visualize a normal pancreas gland. This pancreas head, this is body of pancreas, and this tail of pancreas. These are the relevant structures. This is vertebra, this is aorta, this is IVC, this is portal vein, this is splenic vein, this is superior mesenteric artery. Second picture, this is a picture of chronic pancreatitis. You can see the increased echogenicity of pancreatic gland and atrophy of pancreatic gland and also dilatation of pancreatic duct and pancreatolithiasis. Sonographic findings. Sonographic findings of chronic pancreatitis consist of: number one, change in size in ecotexture of the pancreas. Number two, focal mass lesion. Number three, calcifications. Number four, pancreatic duct dilatation. Number five, bile duct dilatation and portal vein thrombosis may be associated findings. Number one, change in size in ecotexture. In chronic pancreatitis, the gland shows no swelling, rather it is hypotrophic. It is only the course of reactivation that a frank swelling occurs. Ecotexture is simultaneously hyperechoic and heterogeneous. Contours of the gland in chronic pancreatitis may be irregular. Number two, focal mass lesion. Occasionally, chronic pancreatitis may produce a focal fibrotic mass which is hypoechoic as compared to the rest of the gland. It is indistinguishable from a malignant mass. Further, if the mass is within the head, it may produce obstruction of the bile duct like a true neoplasm. FNAC may differentiate. In these two pictures of chronic pancreatitis, in first picture, you can see the ecotexture of the pancreatic gland. Echogenicity of the pancreatic gland is increased and the size of the gland is decreased. In second picture, you can see a hypoechoic lesion within the head of pancreas. How to differentiate from a neoplasm? We can differentiate this through FNAC. Number three, pancreaticolithiasis. The classic sonographic sign of chronic pancreatitis is pancreaticolithiasis. It is multiple, punctate, hyperechoic, intraductal calcified foci, which may or may not produce a shadow depending upon their size and extent. Calcification forms as a consequence of increased pancreatic protein secretion and subsequent calcification of intraductal protein plaques. Number four, dilatation of the pancreatic duct. Dilatation of the pancreatic duct is another sign of chronic pancreatitis. In many cases, associated short structures produce alternating area of narrowing and dilatation that are referred to as string of beads. This is in contrast to smooth dilatation, which is thought to be due to malignant obstruction or acute gallstone pancreatitis. In this picture, you can see pancreatolithiasis, multiple echogenic foci. Some of them are giving shadows. The shadows depend of their size and extent. This calcification are due to increased pancreatic protein secretion. In second picture, you can see pancreatic duct dilatation. It is more than 3 mm. In many cases, associated short structure produce alternating area of narrowing and dilatation that are referred to as a string of beads. This is in contrast to smooth dilatation, which is thought to be due to malignant obstruction or acute gallstone pancreatitis.